Hi guys, this is John Adamson, the Rehab Documentation Guru, coming to you live from Caroline County in Virginia, home of the Virginia State Fair. And what we're going to do today is look at some common documentation mistakes that PTs make when it comes to gait analysis and support for ongoing medical necessity of services. And this is an actual example of documentation which I gussied up slightly to change a couple parameters and make it consistent with what I often see. And let's look at the example and then let's break it down. Patient ascended, descended 4 to 6 inch steps with bilateral handrails and contact guard assist with alternating step pattern. Ambulation 50 feet times 2 with rollator and standby assistance. Now, I've not only seen this as analysis statements, but I've also seen it as treatment statements, and that's a whole nother problem. First of all, this is not a good analysis, and if you've seen my video on a proper blueprint for an analysis, you'll see why pretty quickly with a comparison only of function here, and there's no analysis of underlying impairments, but this is sometimes what I see. And I will tell you that based on that documentation, this is a good setup for a denial based on denial trends and denial statements made by the nurse reviewers that are looking at these claims. So first of all, let's look at the step height. How is this going to correlate with an actual functional outcome? Now, I understand, we've all been in the gym where we have those two-sided staircases. One side has the 4-inch, 6-inch steps, like the half-size ones, and then the other side has the 8-inch steps, which is more of a common step height that we see. And sometimes, if you've been in the home health environment, you'll see even taller, slightly taller steps that patients are being required to do. And so, first of all, I would advise this therapist to get a little bit more specific. 4 to 6-inch, that's kind of a big difference. So actually get the measuring tool out and find out exactly what these steps are rather than just coming up with a range. Secondly, I would advise this therapist to analyze the specific capability of the patient on standard steps. Let's say this patient's going home and they've got 3 steps to enter their home with a unilateral rail. That's the kind of setup I'd want to assess them on and then document accordingly to demonstrate what still needs to be done for them to go home. I don't trust nurse reviewers to look at this kind of documentation and make a correlation between this and what a typical setup is going to be in the home environment. What we've just told them by this statement is the patient's got contact guard capability on stairs. And Medicare Part A, we're seeing a lot of denials, whether it's standard Medicare or managed Medicare, when patients get to contact guard assist level for functionality, any functionality, then we're seeing denials of those claims because Medicare is saying they're ready to safely transition to the next level. So this is sending the wrong message, and this is a common mistake I see. Also, the patient's doing alternating step pattern, which sounds fairly normal, a reciprocal step pattern. And now let's look at otherwise the gait. The patient can ambulate 50 feet. And you might have had experience with being told that if the patient can walk 50 feet, they can go home. That's not necessarily true. There's no specific guideline about that. But, most patients, once they get in their home, 50 feet is going to be more than functional. If they're standby assist, they really don't need somebody with a lot of physical capability to keep an eye on them. And so this is sending the wrong message, and it's not a documentation of why can't they safely and effectively go to their home environment or to the next level of care if they're staying in an inpatient setting. And so we want to make sure that our analysis is truly looking at what's their function going to need to be when we're discharging them, and what's going to prevent them from safely and effectively going to the next level of care, whatever that might be. So let's look at some better examples on the next slide. So now we're going to look at cleaning it up a little bit and get into some statements that sound a little bit more supportive of what we need to get across to the Medicare reviewer or the other third-party payer. Now, keep in mind, these might be a little bit wordy. You could probably reduce some of this verbiage to make it a little bit more statement than full sentence oriented and still get the same message across. So one aspect of analysis related to stairs might be this. While patient can perform 4-inch steps with contact guard reciprocally in the rehab gym with bilateral upper extremity usage or support, patients unable to perform standard 8-inch risers without moderate assist for lifting legs with single rail. And of course, we want to talk about what are we trying to simulate here? Because if we have a goal on stair climbing, what's their discharge capability need to look like? And performs 1 step at a time. Now we're giving a little bit more evidence that, well, they're not quite ready to safely do this on their own in a home environment. Here's another example related to the gait. Patient cannot safely be discharged at home at current gait level of contact guard assist due to having no willing, able caregiver in discharge environment. Patient requires contact assist due to. And here's where I would use a standardized test that correlates with fall risk. We've got different tests that might give you a correlation with high, moderate, and low fall risk. We've got some tests that might correlate with, this is the kind of device they need for this kind of setting. For example, the Berg Balance Scale, don't quote me on this, but has some data that supports you need this Berg score to be a safe and effective ambulator on level surfaces without a device, or a safe and effective community ambulator. We want to use the data that's available to us with standardized tests to support why do they need their current level of care that we're providing them. And then going on from there, the patient's ambulating 50 feet, but that doesn't say why they cannot safely and effectively do that 50 feet on their own. And so we might say something like this. Patient's gait distance is limited due to. And so here we want to include like specific and measurable underlying impairments that are preventing the patient from safely and effectively. Always keep those words in mind. Doing this on their own or doing it with a non-skilled, non-licensed, non-billing entity, which is you. So you're the billing entity. You want to transition them off your care. But before we do that, we want to prove that they need ongoing special skills, special knowledge to safely and effectively work with them. If we can't prove that in our analysis, then we have proven the reviewer's point, in this case, that they could probably safely and effectively be discharged from your care setting. One of the things that we have to remember about doing analysis or any documentation really is you might have noticed that in the first scenario and the second scenario, probably the same stuff is going on with the patient, but it's about the presentation. And I'm not talking about making things up and just putting like lipstick on a pig, for example, but I'm talking about giving real data that supports the ongoing medical necessity of what you're doing and why they need your care. And gait analysis is one of those things that therapists generally don't do a very good job in. One of the things that I didn't show in this particular example, just because it wasn't entirely relevant, was getting into the nitty-gritty of the gait analysis itself, like step length, toe clearance, cadence, things like that, that further demonstrate that gait is something that a PT, in this case, should be working on. And by doing that, by breaking down those underlying impairments, you're demonstrating special skills and knowledge that make you the most safe and effective means to get the patient to their goals that allow them to safely and effectively discharge from your environment. Anyway, I hope you found this video helpful. Again, this is John Adamson, the Rehab Documentation Guru. Thank you all for your support, and if you have any comments or suggestions for further videos, please leave them in the comments below. Take care, God bless, and make sure you get paid for what you do.